is my pleasure and honor to introduce my chair, Professor Bitzer. He is Professor Emeritus from Basel and also the Editor-in-Chief of the European Journal of Contraception and Reproductive Health. He is going to present an overview of perimenopausal contraception.
Thank you very much. These are my disclosures. Well, what are the characteristics of the perimenopausal life phase? I think we do have well-known biomedical characteristics like a decline in fertility, an increase in miscarriage, chromosomal abnormalities, pregnancy complications. We have the endocrine progesterone decline and estrogen fluctuation with irregular and heavy bleeding, climacteric symptoms, bone demineralization. We have a risk for increase in cardiovascular diseases and also for a risk for gynecologic neoplasia. We will talk about this a little bit later. But we also have psychosocial characteristics. Very often these women, there is a family planning ambivalence. Should I have one more child, a final child? There is the situation that very often these women have adolescent children and they have to care for parents at the same time. There are professional career challenges at maximum and a decline in energy. There is sometimes burnout and depression, and there is very frequently loss of sexual desire. So the major health challenges are one, age-related issues like increased cardiovascular disease, cancers, osteoporosis. There are perimenopause, so more endocrine-related negative impact on quality of life, iron deficiency, climacteric symptoms, depression, sexual dysfunction. And there is, as I mentioned, the age-related increase in high-risk pregnancy and fetal abnormalities. So it's a very challenging issue and very important with respect to providing good health care in a phase where you go towards aging. Very briefly, the cardiovascular risk and age, there is this clearly age-related increase for venous thromboembolism, but also for arterial diseases. And I think my last speaker will also go into more detail into this. But I think we have to be aware that, you know, the incidence of venous thromboembolism in young women is 1 among almost 100,000 or 3 or 4 among 100,000. And then it goes down at a 40-year-old lady where the frequency is something like 3 in 1,000, so it's much more background risk. Cancer risk and age, this is also from the faculty, their paper they published on perimenopausal contraception, and you can see that the risk of breast, endometrial, ovarian cancer increases with age, while the risk of cervical cancer decreases. About 80% of breast cancers are in women aged 50 or older. Ovarian cancer is much less common than breast cancer, but increases also considerably, exponentially actually with age. Endometrial cancer is primarily a disease of the old age and it can occasionally affect younger women, as you all know. Conversely, the rate of cervical cancer declines and it is highest in the UK, for example, for women aged 25 to 29. The other issue is during the menopausal transition, the incidence of sexual dysfunction, sexual complaints increases. This is the very famous, already older study of Lorraine Dennerstein, the longitudinal studies. We know about perimenopausal bone density loss. We know about climacteric symptoms, and we know about the prevalence of heavy menstrual bleeding, which is a very frequent complaint of women in this age group. And as you all know, this may contribute to iron deficiency, but also has an important impact on quality of life. What frequently is a little bit overlooked is the fact that there is the risk for first onset of major depressive disorder is quite high in perimenopause, especially in those women in the perimenopause who have vasomotor symptoms, as you can see here from this slide. So what is our task? Of course, it's the prevention of high-risk pregnancies. We do not want to have an increase in in cardiovascular disease, even if possible, protect against age-related increase in cardiovascular disease, cancers, and osteoporosis, and if possible, also not aggravate or even alleviate the perimenopause-related negative impact on quality of life, like heavy menstrual bleeding, iron deficiency, climacteric symptoms, depression, and sexual dysfunction. So it's really a big task and quite a bit of a challenge. If you want to put it into practice, we have developed and proposed what we call the contraceptive triangle, which means that we have to bring sort of three variables together. One is the woman's profile, the context in which she lives, and the method profile. What is actually meant by these issues? If you look at the large contraceptive cafeteria or toolbox, you can see that the method profile, there are four characteristics: the efficacy and effectiveness, the health risks, the side effects, which have an impact on quality of life, and the health protection and the additional benefits. So these are the four major characteristics of a method which are important for the woman. What about the woman's profile? She has her contraceptive needs, which are very individual, which are very cultural, which are very subjective. She has her medical profile, which is quite objective, like diseases, drugs, risks, symptoms. And she has her psychosocial profile, which is about behavioral risks, smoking, overweight, stresses, mental and sexual health, and other symptoms. And the third variable, which I'm not going to talk about, but which is, of course, internationally important, is the context. The woman and the healthcare professional, they work in a certain cultural environment, in a health system, in a socio-economic environment, which will, of course, also have an impact. But let's go back to the main methods. So the big five: copper IUDs, LNG IUDs, Implanon, combined hormonal contraceptives, DMPA, and progesterone-only pills. Now, for all of them, age alone is not a contraindication by age only. They all have category 1 or 2 in the UK. Let's have a look at the copper IUD. Highly effective, and I put the evidence level sort of behind it. We do have very nice evidence level of this high efficacy, as you all know, because it's not user-dependent. As far as we know, there is no cardiovascular risk, no cancer risks. There are the rare complications of perforation and expulsion. We do have clinical studies showing that there is hypomenorrhea, dysmenorrhea. There may be lower abdominal pain, but the frequency is usually quite low. And then we have possible additional benefits, and this is actually cervical carcinoma, now with the evidence level of 2, that copper IUD users are protected against cervical carcinoma. The LNG IUD is even a little bit more complicated. It's also highly effective, as you know very well. There is no cardiovascular risk on an evidence level 1. The breast cancer risk is conflicting. It's probably low or even none. It disappears after 10 years. You have the new study from the Denmark group, but we can maybe discuss it a little bit later. There may be some small risk increase, and of course the rare complications are the same like for the copper IUD. What is the the side effects are the bleeding irregularities, the amenorrhea, and now more and more reported mood disturbances, but this is on a large cohort without good controls. What is the health protection? It's probably protecting against endometrium carcinoma, and of course it is indicated for the treatment of heavy menstrual bleeding. Implanon, the other progesterone-only LARC, is perfect use, high. There seems to be no cardiovascular risk as far as we know, no cancer risk. Of course, there are much less studies, much less data about Implanon compared to LNG IUD. You have the irregular bleeding, you have sometimes the heavy bleeding, you have sometimes androgen-related side effects like acne, and there is the issue of weight gain in some patients. The additional benefit might be endometriosis, dysmenorrhea, and ovulatory pain. What about the progesterone-only pill? Actually, it would be very effective if it's used regularly because it's ovulation inhibition. There is no cardiovascular risk. There is no cancer risk known and no decrease in bone mineral density. So we have irregular bleeding. We may have an impact on mood and skin, but there are very few studies about it. The benefit is dysmenorrhea, ovulatory pain, endometriosis, and menstrual migraine. Depo-Provera, perfect use, it's highly effective. We do not exactly know whether there is a slight increase in VTE. There is some controversy going on also about cervical cancer risk. You all know that there is the bone mineral density diminution in the beginning, which is usually recovered, and which is interesting enough not aggravated by menopause. We have irregular bleeding, amenorrhea, and especially, of course, the issue of weight, of possible weight gain. There is some indication that it may protect against endometrium carcinoma, but the evidence level is not very high. Finally, the combined hormonal contraceptives, the most complicated issue because it has a lot of potential, but it also has probably the highest risk profile. It's user dependent. The VTE risk is increased. The breast cancer risk seems to be increased. Small, but it disappears. Cervical cancer risk 1.2. Other risks are not well. The absolute risk increase, however, in these risk categories is quite low. We do have a lot of possible side effects which are not clearly related, actually, because if you compare it to studies with a placebo, you find similar risk profiles. But there is breast tension, headache, irregular bleeding, acne, mood changes, irritability, mood swings, low libido, and sexual pain reported. But there is a huge list of protective and benefits. It clearly protects against ovarian and endometrial cancer, probably also colorectal cancer. It's an osteoporosis prevention. It reduces climacteric symptoms. It reduces heavy menstrual bleeding. It reduces hyperandrogenic skin symptoms. In many women, it may even be a mood improvement due to the estrogen, and improvement of sexual function is also clearly described in sexological studies. So here we are. We have this profile of the method. Now, how can we apply it to the individual woman? We have developed what we call the three-step approach that first, if you look at the values, the concerns, and the beliefs of the woman, you have to listen to her. What are her needs? Does she need regular menstruation? What about her fear of cancer? What about her concept about hormones, foreign body, etc.? So listening to her, this will allow you to exclude methods which the woman does not want or she's not enough informed about, where you have to respond to, and which may already include some of the methods of your contraceptive toolbox. The other thing, the next step, is what you usually do. You look at the risk and medical history profile, and by using this, you can exclude methods which the woman must not use for medical reasons. And this is usually done by looking at the medical eligibility criteria, as you have it here from the faculty or from WHO. And you can see for the combined hormonal contraceptive, there are these well-known categories 3 and 4. Regarding also other exclusion criteria, you can look here for intrauterine contraception. What are the shared medical eligibility criteria between copper and LNG IUS? It's a pelvic inflammatory disease, it's a sexually transmitted infection, acute, it's cardiac arrhythmias, it's uterine fibroids, it's anatomical abnormalities, it's cervical cancer, where you have to look into possible limitations of use. If you look at differences between copper IUD and LNG IUD, it is mainly breast cancer, which is the predominant issue in this context. If you look at the progesterone-only based contraception, where you have this large advantage that you don't have cardiovascular risk, you have also to look into possible differences, for example, a history of high blood pressure during pregnancy, where you would be careful with Depo-Provera. I think it's mainly a small difference in risk compared Depo-Provera with the other progesterone-only progestogens. Their shared contraindications are breast cancer, decompensated cirrhosis, hepatocellular carcinoma of the liver, and unexplained vaginal bleeding, which are rare, of course. Finally, we look, when you have done the 2 steps to exclude methods which a woman should not use and the woman she does not want to use, then your 3rd step is that you would look for a method which would fit the expectations and provide additional benefit. This is, of course, that if you have risk of osteoporosis, you want to give estrogen. If you have PCO, you want to give anti-androgenic progestogen. If you have family risk of ovarian carcinoma, you want to give combined hormonal contraceptive. If it is a question of ease of use, you want to give the long-acting. And if you have different symptoms which are differentially treated by different progestogens, irregular bleeding, dysmenorrhea, hyperandrogenic signs, PCO, PMS, and PMDD, and you know that we do have different preparations for that. So I think somehow my last slide has been put away, but I try to give you an overview focusing on the very challenging task of finding the appropriate contraceptive method for the individual perimenopausal woman, which conveys a lot of potential for a broad women's health care concept. Thank you very much.
Thank you very much, Dr. Thank you very much.
And thank you to all of you for being here at this symposium this morning. I too took some offense to as there's more birthday candles on my cake every year, to the older woman, so I am going with the need for contraception in the later reproductive years. Johannes has given us a very good overview of what type of contraception and some risks about that. So I'm going to talk a little bit about the need for contraception in the later reproductive years. So first, my disclosure slide, and I would like to point out that I will be discussing some off-label uses of some of the medications and devices. So for this part of this session, I wanted to identify the need for contraception in the later reproductive years, help you to identify the risks of pregnancy and balance those off against the risks of contraceptive use that Professor Bitzer talked about earlier, discuss strategies for stopping contraception, and then how to transition to hormone therapy. And then hopefully at the end of this, you'll have at least 4 clinical pearls that you can take home and implement immediately into practice. So there's often a lot of questions about what to do around contraception in the later reproductive years, like do women even need it, and what's safe to use, and well, when do you stop it, do you transition, at what point do you start it? So these are some of the questions hopefully we'll be able to answer for you this morning. So first off, identifying the need for contraception in the later reproductive years. So what is actually the likelihood of pregnancy? So the risk of pregnancy, we know, gradually declines with increasing age because there's diminishing oocyte quality in ovarian reserve, and you get an associated increase in ovulatory cycles and luteal insufficiency, and there's often a decrease in coital frequency as well. But there is still evidence of ovulation. So up to 88% of cycles up to 5 years before menopause, and in 23% of cycles within 1 year after the final menstrual period. So the chance of a naturally occurring pregnancy is about 30% per year between the ages of 40 and 44, and that decreases down to 10% per year between the ages of 45 and 49. And that's compared to a chance of pregnancy of about 85% when someone is in their 20s. And of course, spontaneous pregnancy over the age of 50 is rare. So if you look at women who didn't start trying to conceive until they were ages 40 to 44, one study showed that 64% of those women would ultimately remain childless. Now, I always like to look and see what they say in the Guinness Book of World Records, and I always look to see if these numbers have changed at all. But according to that, the oldest pregnancy that's ever occurred spontaneously occurred in the United Kingdom to a woman who conceived spontaneously at the age of 59 while she was on estrogen. So yes, it's rare, but it could potentially happen. So if there's that risk of pregnancy, are women in this age bracket using contraceptive methods? And in fact, age is a significant predictor of non-use of contraception. So if you look at the National Survey of Family Growth, which was conducted in the United States, they found that 24% of 40 to 44-year-olds were not using contraception. And the odds of not using contraception are significantly higher in that age group compared to the 20 to 24-year-old age group. We had similar findings in Canada when we did our national study a couple of years ago, and we found that the odds of always use are much lower in women over 40 compared to younger women. Why is that? Well, maybe it's a lower perceived risk of pregnancy, maybe they're having intercourse less frequently, so they're not as concerned about. But the problem is if they're not using it or they're using it inconsistently, that can result in an unintended pregnancy and potentially abortions. And do we actually see that? Yes, we do. So again, looking at the National Survey of Family Growth, we found that in women over the age of 40, 48% of pregnancies are unintended, and of those, almost 50% ended in abortion. And looking at abortion rates, about 35% in women over the age of 40, and the percentage is even higher over the age of 45. Similarly, in England and Wales, they found that 28% of recorded pregnancies in women over 40 ended in abortion, and that's not including pregnancies that may have ended in miscarriage or ectopics. And in Scotland, 4% of all terminations in 2016 were to women over 40 years. So bottom line is, contraception must be practiced if pregnancy is not desired. I don't want you to forget about the fact that these women actually, the need for condoms, because we're always talking about condoms in our younger population. I think we're all remembering to tell our adolescents to use condoms, but individuals in the later reproductive years may also be entering into new relationships, which brings with it an attendant risk of STIs. We know that, and that's probably because condom rates tend to decrease with older women compared to younger women. Healthcare providers just don't tend to think about it or recommend it, and don't think about STIs as being a risk. And it just may not seem as relevant once the risk of pregnancy is no longer there. But the rates of chlamydia, gonorrhea, genital warts, herpes, HIV, they've risen in many countries in women over the age of 40. So healthcare providers should still discuss condom use and STI protection even after contraception is no longer required. So next objective, what are the risks of pregnancy versus the risk of contraceptive use? So I'm going to ask you this question. So healthcare professionals should advise women that pregnancy and childbirth after age 40 years confers a greater risk of adverse outcomes compared with younger women because A, maternal mortality rate for women over 40 is twice that of women aged 20. B, there are higher rates of pregnancy-induced hypertension. C, the miscarriage rate rises to over 70% for women over age 45. Or D, a woman age 45 has a 1 in 18 chance of having a baby with Down syndrome. So, what do you guys think about that? Okay, someone said all of them are correct. So the correct answer for this is actually there are higher rates of pregnancy-induced hypertension. The maternal mortality rate in women over 40 is actually 3 times that of women aged 20. The miscarriage rate is about 50% at ages 40 to 44, and then once you're over the age of 45, it actually goes as high as 90%. So yes, over 70%, but actually almost over 90%. And the chances of having a baby at term with Down syndrome at the age of 40 are 1 in 85, and at the age of 45, it increases to 1 in 35. So remember that, as Professor Bitzer pointed out, sometimes with increasing age, we get some additional comorbidities, which may also impact risk of pregnancies. So when we look at maternal morbidity, we see that there's an increased risk of early pregnancy loss, gestational diabetes, gestational hypertension, severe preeclampsia, placenta previa, postpartum hemorrhage, and operative delivery. And from the fetal point of view and neonatal point of view, we see that there's an increase in chromosomal anomalies, preterm birth, low birth weight, and stillbirth. So when you're talking to women about contraception and the risk of contraception, it's also important to address the actual risk of pregnancy. And then, because for most patients, the health risks of pregnancy will generally outweigh the risks of contraception. So third objective was to look at when do you stop contraception and how do you go about transitioning to hormone therapy. So going back to the previous presentation, there's lots of different options out there. None of those options are contraindicated on the basis of age alone. Now, some things may become more appealing to a woman in her later reproductive years, things that may have had a lower inherent efficacy or effectiveness that may not have been acceptable when she was younger, but with declining fertility may be more acceptable now, especially if there's a decrease in frequency of intercourse. But I don't want you to forget about emergency contraception. Because if someone isn't using contraception regularly and if someone's having infrequent intercourse, when it does happen, there's that possibility it's been unprotected. So you want to remember about emergency contraception. So many countries have the levonorgestrel emergency contraception, ulipristal acetate EC, as well as, of course, the copper IUD. So I'm going to ask you another question. So in terms of contraception for women in the later reproductive years, which statement is true? Contraception can be stopped at age 50 as the risk of pregnancy is extremely low. B, the progestin-only implant should be stopped at age 50 as the risk of pregnancy is extremely low. C, women over 40 using the progestin-only injection should be counseled regarding other methods of contraception as there are safer methods that are equally effective. Or D, stopping combined hormonal contraceptives at age 50 should be considered as there are other methods that are equally effective and potentially safer. Okay, so this is, I'm not surprised to hear different things because it is sometimes controversial, but yeah, so they're similar, but that's why I put them in there. So the correct answer, the most correct answer is probably D. And that's because contraception really should be continued until the age of 50 when natural sterility can be assumed, unless menopause is diagnosed. Because of that, the progestin implant similarly can be continued until the age of 55 and 55. The implant similarly can be continued till the age of 55. If a woman doesn't have any other significant risk factors for osteoporosis, you don't necessarily need to change them at the age of 40 if they're using injectable progestins, but it may be something that you discuss with them on an ongoing basis. But because we don't have good evidence either confirming or refuting the safety of combined hormonal contraceptives, and because women may develop concomitant comorbidities that may further increase their risk of being on a combined hormonal contraceptive, it's suggested that we may want to consider looking at alternative methods of contraception at that point. Not saying that you have to change it, but it should be considered. So again, special considerations. In general, contraception can be discontinued in all women by the age of 55. And remember, many women will be experiencing perimenopausal symptoms, and using hormonal contraceptives may actually help improve their quality of life. So that's something that we need to consider when we're talking to women about their options as well in this time. So I'm just going to start off with the levonorgestrel IUS and the copper IUD. So starting off with our most effective methods of contraception. So I'll ask you this, and this is an easy one, so you don't have to think it's quite so hard. A woman who has a levonorgestrel IUS 20 inserted at or after age 45 and is amenorrheic can leave it in until she is postmenopausal. True or false?
True.
So in fact, it's true. And I'll talk about that a little bit more as well. But it actually can be left in until she's postmenopausal. Okay, well, what about the copper IUD? True or false? A copper IUD should be removed 1 year after the last menstrual period in women aged over 50 years. True or false? Yeah. So a little less controversy about that. It's true. It's not really required anymore. So with women who have a levonorgestrel IUS 20, so that is the Marinas, the trade name for it, inserted at age 45 or older, can use the device for 7 years, and that's still considered off-label, or if they're amenorrheic until after the menopause. So really, it can be used up until the age of 55 if it's for contraception or for having menstrual bleeding. So notice I'm not saying for hormone therapy there. Women using intrauterine contraception should have it removed once menopause is confirmed and contraception is no longer required. And the reason for that is there are some case reports of actinomycosis-like organisms in pyometra postmenopausal IUD users. So that's the reasoning behind that. You don't really need it anymore, and if you can safely remove it, it's probably better to have it removed. Okay, so another question. This one's a little harder, not just a true or false question. A 50-year-old woman, and this is something I'm sure you've all seen, a 50-year-old woman attends for removal of an IUC. She is unsure which device was inserted 5 years ago. She's had irregular light bleeding for the last couple of years. She takes no medication but reports menopausal symptoms. Which statement is false? A copper IUD inserted at or after age 40 can remain in situ until 1 year after the last menstrual period if it occurs when the woman is 50 or older. B, if she considers taking hormone therapy, a Mirena, which is so the levonorgestrel IUS 20, used as part of a hormone therapy combination, must be changed every 5 years. C, if the IUC is removed, she must be advised to use another method of contraception. Or D, if a levonorgestrel IUS 20 or the 13.5 milligram levonorgestrel IUS, which is the levonorgestrel 8, is being used for contraception, it can remain in situ until menopause. So sorry, I'm making you think a little harder for this question. Okay, so here's some D's, and yep, the D is correct. The copper IUD, if it's inserted, as long as it has at least 300 millimeter squares of copper on it, if it's inserted at or after age 40, it can actually remain in there until you've diagnosed menopause, so it can stay in there for quite some time. That is off-label for a number of IUDs. And if she wants to take hormone therapy, you can actually use the Mirena, the levonorgestrel IUS 20. It is approved in many countries for use as the progestin component of a hormone therapy program. If this particular patient, the IUD is taken out, she should be advised to use another method of contraception because she is bleeding still, so we can't necessarily diagnose menopause in her, so that's why she should use another. And then the levonorgestrel 8, IUS 8, is really only approved for 3 years, so that's why it shouldn't be left in longer than that. And we don't have more evidence on that I'm aware of. So using the levonorgestrel IUS 20 for hormone therapy, and the nice thing about this is it kind of can coast. I always talk about coasting into menopause because you can use it to transition from your contraception and maybe treatment of irregular bleeding right into hormone therapy. And there is extensive data that the levonorgestrel IUS 20 protects against the stimulatory effects of estrogen on the endometrium. And in many countries, it is approved as a progestin component of hormone therapy. At this time, to guarantee endometrial protection, if it's being used with estrogen for hormone therapy, it is recommended it be changed every 5 years just because we don't have more data on that. It's probably effective for longer than that, but right at the moment it's approved for 5 years of use in the places where it is approved, and that's irrespective of age at the time of insertion. So for this particular patient, if we look back here, if she decided to have to use this as part of hormone therapy and she was using estrogen to treat her menopausal symptoms, then she should have a new IUD inserted. So the progestin-only contraception that Dr. Bitzer has already spoken about were the implants, injectable progestins, and progestin-only pills. So another question, women using depo-medroxyprogesterone acetate experience initial bone loss due to hypoestrogenic effects of DMPA, but this initial bone loss is not repeated or worsened by menopause. This statement is true or false? Yeah, it's true, and I think you kind of got a little help in the previous presentation with that, but yes, that's true. We all know that DMPA decreases bone mineral density, probably due to that relative hypoestrogenemia. But what's interesting is that postmenopausal women who have used DMPA, even up until menopause, do not have lower BMD compared to never users. And they enter the menopause on DMPA, they've already lost that bone density that they would lose due to declining estradiol levels during the first 5 years of menopause. And they will not experience that accelerated bone loss, that loss of bone density. Another interesting thing about it is that it can be associated with the hypoestrogenic symptoms due to suppression or FSH-regulated ovarian estradiol production, but it can be combined with menopausal estrogen therapy in appropriate candidates. And then one of the interesting things about the DMPA is that FSH levels are not suppressed substantially during its use. So if for some reason you wanted to be doing FSH levels to look at diagnosing menopause, which I'm not recommending routinely, but if you were doing that, they're not necessarily suppressed with DMPA use. So what about when do you stop it, and what about hormone therapy? Well, you want to consider alternative methods over age 40, and this is what we talked about earlier, if they have significant risk factors for osteoporosis. Otherwise, you want to maybe start considering alternative methods after age 50 because they're equally effective methods that are potentially safer. So if you're going to switch to a non-hormone method, you would want to do that for 24 months because you wanted to make sure that that amenorrhea that they have, you don't count that as the amenorrhea that you need to diagnose your menopause because, as you know, DMPA users might take longer to return to ovulatory cycles and to having menses. And if you switch to another method, then you just use the method-specific advice. If your decision is to continue, then you want to regularly reassess. Theoretically, it should provide endometrial protection in conjunction with estrogen as part of a hormone therapy regimen. However, it's not approved for use for this. With the implants, the nice thing about them is they're not associated with an increased risk of ET, and they're not associated with a risk of decreased BMD. So when do you stop it? It can be stopped at age 55. And in these women, extended use for up to 5 years may be appropriate as well. But again, that would be off-label. As hormone therapy off-label, it does provide adequate endometrial protection when estrogen therapies are being used to treat perimenopausal or postmenopausal symptoms, but that is off-label use. The progestin-only pill has very few indications. It doesn't have an effect on BMD. It doesn't suppress the menopausal rise in FSH, which is nice, and it can usually be stopped at age 55. It can be used as contraception alongside sequential hormone therapy, and theoretically, it should provide adequate endometrial protection as part of hormone therapy, but there's no experience or no evidence to support that, so that's not necessarily recommended. So lastly, the combined hormonal contraceptives. Although age over 50 is not a contraindication, it is recommended that you start using caution just because we don't have a lot of evidence to either support or refute its safety in it, and women may be developing other comorbidities as well. So you need to tailor that approach. And in fact, the Faculty of Sexual and Reproductive Health doesn't recommend continuing it over the age of 50. So it is suggested that you discuss other alternatives. Not saying that you can't do that, but you certainly might want to talk about other alternatives that may be safer, but you may still end up staying on that. They don't delay menopause, because some people think that, but they may mask it, so withdrawal bleeding may continue, and they may not experience the menopausal symptoms except during the hormone-free interval. Now, once they stop it, they may experience amenorrhea, or they may experience menopausal symptoms. So everybody likes flowcharts because it helps to make things a little bit easier, and I see everyone's cameras up, but this will all be available to you afterwards. I think the Congress people are making sure that you have access to this. So if you don't get a good shot, don't worry, it'll be in your, you'll be able to access it later. So one of the issues with combined hormonal contraception is we really don't know as much about the safety of ethinyl estradiol. What about the different doses, and are some estrogens potentially safer than others? And hopefully we'll have evidence coming forth in the next few years to help make those decisions. So again, another table just to help guide you in your decision-making process. So lastly, just the hormonal therapy is the most effective therapy for the medical management of menopausal symptoms, but hormonal therapy alone does not contain a high enough dose of hormones to provide reliable contraception in perimenopausal women, okay? So I'm going to skip that. So just remember that. The combined oral contraceptive pills provide reliable contraception, but hormone therapy does not. Okay. So again, this is another thing just to guide you on what options you can use in conjunction with hormone therapy. Basically, you can see levonorgestrel IUS is safe to use along with estrogen and does have approval for that, but the current recommendations are for no more than 5 years. The implant, the injectables, the progestin-only pill, it can be used as contraception alongside sequential hormone therapy, and although they're likely to be effective for endometrial protection, we don't have evidence to support that. Just remember the combined hormonal contraceptive, you don't use those in combination with hormone therapy. You don't need to do that. I've seen that happen. Okay, so again, lots of myths and facts that are out there. You can help dispel all of these myths that I have listed there because these are all myths, and I've just given you the facts to counteract those. So just in summary, although fertility and fecundity declines with age, you still need to use effective contraception because pregnancies in the later reproductive years are associated with higher risks. Healthcare providers should also remember to talk about STI protection in this particular age group. Most contraceptive methods can be safely used until the age of 55, until the natural loss of fertility can be assumed. Once you get to 50, maybe consider other methods if they're using combined hormonal contraceptions or DMPA. And for women using hormonal contraceptives, menopausal status and lack of need for contraception can be assumed at age 55. And of course, we always consider the whole picture, as Dr. Bitzer, Professor Bitzer was already saying. So thank you very much.
Thanks very much to the organisers for inviting me, and good morning to you all. And yes, my talk is slightly different because I'm talking to you about the non-contraceptive benefits of contraceptives. So a lot of it is off-label or at least questionable. These are my declarations of interests. So let's start by classifying contraception, and we've done that already, but there are permanent methods, there's long-acting reversible contraception, there's medium-acting methods such as the depot injections, shorter-acting methods such as combined pills or progestogen-only pills, barriers, withdrawal, fertility awareness, lactational amenorrhea method, very reliable, and postcoital emergency contraception. And we can take those last three out of here for the rest of the talk today. If we look at these remaining things, then there is some benefit in permanent removal of the fallopian tubes in that it appears as though it will reduce the risk of epithelial ovarian cancer. So there's one fringe benefit from permanent contraception. The levonorgestrel intrauterine device has a number of non-contraceptive benefits. Barrier methods will, as Amanda, I think, mentioned, reduce the risk of sexually transmitted infection, so another non-contraceptive benefit. And then the major issues, I think, will confine our discussion to hormonal methods. And because we're talking about non-contraceptive benefits, we need to be mindful of these medical eligibility criteria. They vary slightly around the world. These are the US ones, but the WHO ones are similar, and certainly similar in Australia. And as the previous two speakers have already mentioned, pretty well everything we're going to talk about today for women in their 40s, let's say, is either category 1 or 2, which means it's okay. The combined hormonal contraceptive for women over 40 is category 2, but that includes women who are overweight or who have diabetes, except if they have had diabetes for more than 20 years, in which case, of course, their risk of vascular disease is much higher, and that puts them in a MECA category of 3 or 4. If they smoke more than 15 cigarettes a day, their risk of arterial disease is increased. If their systolic blood pressure is over 160 or their diastolic over 95, then they're also MEC 3 or 4. And of course, if they've had a stroke or an infarct, then they're category 4. So it all sounds pretty gloomy, and as Amanda also, Johannes mentioned, I think, the risk of VTE is something which crops up all the time. And certainly in my country, if you Google some of the oral contraceptives, you will find lawyers offering to defend you against the overwhelming risk of stroke or thrombosis. And that's just not true. We do know that all combined hormonal contraceptive users with no other risk factors are at some increased risk of VTE. We know the risk is highest in their first year of use, because that's when we're identifying people with underlying risk factors. And we know their risk is increased by obesity, by immobilisation, and by air travel. But as I said, the risk of VTE is not increased by smoking. VTE risk is increased by vaginal delivery systems which contain ethinyl estradiol, but perhaps not estradiol. And for most women, the change in VTE risk will be between, as has been already mentioned, 1 to 4 per 1,000 women per year. There's no need to screen for thrombophilias unless there's a personal or family history of VTE, and it's possible that the estradiol-based preparations are a bit safer. And just as an aside, as you know, for postmenopausal hormone therapy, transdermal estrogen does not increase VTE risk according to large observational studies. So this is about the risk. You can see it varies slightly with the dose of estrogen, and these are all ethinyl estradiol pills, and slightly with the type of progestogen, so that the risk seems to be higher, with some studies looking at cyproterone as the progestogenic agent and others with drospirenone looking at the progestogenic agent. But I should point out that the retrospective database studies show increases, and the prospective registration studies did not show increases. So there's still considerable debate. But I think the important thing here is that if we are going to use hormonal contraception for non-contraceptive means, we need to be careful in our selection of patients. And for most patients, it's going to be an approved and satisfactory risk. The benefits are huge, so I should just spend the next 20 minutes convincing you that every woman in the middle of her 40s should be on the pill. It'll restore regular bleeding, it'll reduce dysmenorrhea, it may have some effect on endometriosis, it'll certainly have an effect on heavy menstrual bleeding, although the data is really quite mixed. It'll suppress, at least partly suppress menopausal vasomotor symptoms. There's a positive effect on bone density with the combined pill, and perhaps fracture prevention. There's a reduced risk of endometrial malignancy, a reduced risk of epithelial ovarian malignancy. There's certainly a role for the treatment of acne in any age group, and a reduced risk of benign breast disease. So let's just go through these in order. First and foremost, perimenopausal bleeding. Perimenopausal bleeding is very common. Probably at least 50% of women in the perimenopause experience some abnormality of bleeding, and to that extent we might also say that it's normal. But we do need to remember that although most of this bleeding is dysfunctional, some of it will have a pathological background, and up to 14% of endometrial cancers are seen in premenopausal women. Concurrent ovarian malignancy is more common, and there'll be times, of course, when we see fibroids or endometrial polyps. So functional abnormal uterine bleeding has to be a diagnosis of exclusion. It requires some judgment, but if you're unsure, test everybody. Currently used therapies, non-hormonal, surgical and hormonal, but let's just concentrate on the hormonal ones today. Progestogens, combined contraceptive, and the levonorgestrel intrauterine system. Progestogens stop endometrial proliferation, they stabilise endometrial vasculature, they block unrestricted vessel growth, and they initiate the clotting cascade. They also have hemostatic and anti-fibrinolytic pathways. So they're very important in controlling cycles, and if you ovulate, you'll produce estrogen for the first half of the cycle alone, and in the second half progesterone as well, and that'll give you a regular cycle. If you don't have regular cycles, you're not ovulating regularly. What about the Mirena, the LNG system? Long-acting, we've already heard 5 years, probably longer as you approach the menopause. Rapidly reversible. It is a procedure, so there's an issue there for many women if we're using this for non-contraceptive purposes. Average reduction in blood loss, though, is about 70%. And for about 80% of women, the average menstrual blood loss will be less than 80 mils. Most women tolerate it very well, but there are some side effects, and I think if you have troubles with this, you need to encourage your patients that the first 3 months are the difficult ones. There's often persistent breakthrough bleeding. There can be breast tenderness, mood changes, acne, all of those, which generally settle with time. And of course, there's the issue of uterine perforation, which again is a rare event, but certainly played up in the media. What about combined oral contraceptives? They're frequently prescribed off-label, but there's not a lot of good data. There have been 2 randomised trials conducted using the combined hormonal contraceptive containing estradiol valerate and dienogest, and both of those showed about a 60 to 70% reduction in menstrual blood loss, similar to the levonorgestrel intrauterine system. There's similar data for estradiol and normogestrel combined, and of course, if you're going to do this to reduce bleeding, it's often wise to try for longer cycles to minimise the bleeding time. The American College of ONG has made a firm statement on this subject, which says that menstrual blood loss is reduced by 40 to 50% in women who use cyclical combined oral contraceptives. What about endometriosis? There's quite a lot in the published literature now about endometriosis persisting not just into the 40s but into the 50s. And whilst we'd all agree, I think, that the pill is not a first-line treatment, it's certainly a useful treatment after surgery. It has limited evidence, unfortunately, of significant benefit in terms of relief of pain. But if we choose our progestogen combination in the pill carefully, we're more likely to get a better effect, and once again, extended cycles might be effective. Other potential options for treating endometriosis in this group of women would include the contraceptive implant, DMPA injections, and the progestogen IUD. Dysmenorrhea, Cochrane is pretty non-committal about the levels of evidence for the pill, but some studies do suggest that the pill in extended regimens does improve the problem of dysmenorrhea. There's one study which actually suggests if you use an oral contraceptive pill in the vagina, it may be more effective than oral use for the treatment of dysmenorrhea. The NuvaRing has been shown to, which is the vaginal ring, has been shown to reduce dysmenorrhea from 42% down to 26% after 3 months of treatment. And observational data suggests that the levonorgestrel intrauterine system will also lead to a reduction of about 50% by 3 years of treatment. DMPA and the etonogestrel implant studies showed a small reduction in menstrual pain in patients with endometriosis. And PMS, I think feed a cold, starve a fever, give PMS anything it wants is a fair summary. Up to 75% of women report troubles with PMS, 10 to 15% report symptoms which impair their daily activity, and up to 8% report what we would call premenstrual dysphoric disorder. If you stop ovulation, you can largely get rid of this problem, and so one option would be to use something like a GnRH analogue, but it does have attendant side effects, of course. Depo-Provera has been tried in these cases, as have the hormone implants and the combined oral contraceptive pill. But some women are very sensitive to the hormones, and sometimes the combined therapies will actually make them worse. There have been studies on the drospirenone-containing pills, and they have been approved for the treatment of PMDD in the United States. And once again, of course, extended regimens might help. The levonorgestrel intrauterine system, being a progestin only, may actually make things worse, and there's no good evidence that it's a useful treatment for PMS. Ovarian cysts, similar data. There was early data 40-something years ago which suggested that the pill would significantly reduce the number of functional ovarian cysts. But more recent studies have not been as supportive of that argument. Benign ovarian tumours are less common in ever users of the pill, but almost all of those were endometriomas. The combined pills do not appear to have any added benefits in treating smallish cysts over just being patient and watching and waiting. And most of those cysts will then resolve in 2 to 3 months. And those that don't probably need further investigation because they well could be pathological. I mentioned PID at the beginning. Perimenopausal women are still potentially at risk. They may have a new partner. They may not appreciate the need for contraception, and most specifically for protection against sexually transmitted disease. The oral contraceptive does provide some protection, probably by its effect on cervical mucus, and it's likely that the levonorgestrel and progestogen devices also have a similar effect by changing cervical mucus. And there's some evidence to suggest that PID acquired whilst on the combined pill may be a bit less. Fibroids, regardless of the dose of the pill doesn't increase fibroid growth. The Oxford Family Planning Association some years ago found a reduced risk of myomas in oral contraceptive users, which was about a 30% reduction after 10 years. The risk is significantly decreased in combined pill users, with about a 50% reduction after 7 years in other studies, but some of the American cohort studies are not quite as persuasive. They do reduce heavy menstrual bleeding in women with fibroids, so they still have a role there, but their effect is certainly less than women who have a normal uterus without the presence of myomas. Again, the progestin IUD is a useful option in this group of women, probably more effective than the pill because of its ability to suppress menstrual blood loss, reduces bleeding when fibroids are present, but not by the 80% that you see in women with a normal uterus, may cause a slight change in the size of fibroids, although most of the studies show no change at all. And sometimes it can make placement difficult if these women have submucosal or cervical fibroids in the way. And vasomotor symptoms, Amanda has mentioned that, Johannes has mentioned that. The pill will suppress vasomotor symptoms reasonably well, but if there's a breakthrough, it'll be in the placebo week. And we all know that there are some women who approach the menopause on low-dose pills who still complain of hot flushes for reasons we really do not know. I agree that it's difficult to tell when to stop. The family planning associations in Australia recommend stopping at 51, but there's absolutely no evidence about when to stop or when not to stop, and you, I think, have to approach it in a sensible way. And the most sensible way is when women get to this sort of age is to suggest that they have a break. One of three things will happen. They'll start having periods again, they'll have hot flushes, or nothing will happen, and then they're winners. You should consider the estrogen-estradiol valerate preparations in these women, because probably that will reduce their VTE risk, and they have a shorter pill-free interval as well, and or at least one of them is amenable to extended regimens. And you could, of course, use the LNG IUS with add-back estrogen. There's not much evidence that the pill has a significant effect on bone density and fracture risk in women of a normal weight, but it does have a modest effect on bone density in normal weighted women with hypoestrogenism, for example, athletes and dancers, in women with stress-related amenorrhea, and in perimenopausal women or women with premature ovarian insufficiency. The effect is probably not as great in that group of women as is seen with estrogen-based hormone therapies. Estradiol may be a better choice because it seems to suppress IGF-1 a little bit less and has been shown to be more effective in 1 or 2 small studies in women with POF. So then there's the issue of cancer risk, and this is perhaps one of the most important reasons of all. Every use of the combined hormone contraceptive results in a 12% overall reduction in cancer and 29% reduction in gynaecological cancers. Endometrial cancer reduced by 56% after 4 years and 72% after 12 years. Ovarian cancer reduced by about 27% in ever users of the combined hormonal contraceptive, and by 50% in those women who use it for more than 10 years. And colorectal cancer, at least in one study, was shown to be reduced by 18% in women who used combined hormonal contraceptive rather than non-users. The issue of breast cancer is confused. A case control study from the NIH found no increase in risk. Observational studies show less benign breast disease, but a prospective Danish cohort study with a large number of women, as you can see, found an increased risk of breast cancer use for women who used any form of hormonal contraceptive, the relative risk being 1.2, which translated to 1 per 7,700 women per annum. A meta-analysis comparing different doses found no increase in breast cancer risk for women who used combined hormonal contraceptives using 35 micrograms of ethinyl estradiol or less. And the same study found that carriers of BRCA1 and 2 had a 50 to 51% reduction in ovarian cancer risk associated with combined hormone contraceptive use. Endometrial cancer, hormonal IUDs are used off-label in many countries to treat endometrial hyperplasia with reasonable success. It's probably most useful for simple hyperplasia rather than anything atypical, which I believe requires surgical intervention. There was a Finnish study which indicated the LNG IUD had a protective effect against endometrial adenocarcinoma. The copper IUD also was associated with a reduced risk of endometrial carcinoma. And I've mentioned already the effects of the pill with ovarian cancer, 30 to 50% reduction for users versus non-users, and the risk continuing to increase for up to 30 years after ceasing therapy. Colon cancer, it's likely to be protective in the same way as combined hormone replacement therapy was shown in some studies to be protective. But recent meta-analyses have been less optimistic. Relative risk of 0.81, just statistically significant, but a small change. Large longitudinal studies from the Royal College of General Practitioners found a reduction in risk of 0.72 for ever users versus never users. So just some final thoughts to conclude. When you're using contraceptives for non-contraceptive uses, you certainly need to weigh up all the risks against the potential benefits. And I think if we use medical eligibility criteria and assess our patients individually, we can find a place for hormonal contraceptives to be used for non-contraceptive reasons for many women going through their 40s. It's been estimated that the use of the pill has prevented 30,000 deaths a year from ovarian cancer. The RCGP study, which followed more than 45,000 women for up to 39 years, found overall mortality, that's overall mortality, amongst combined oral contraceptive users was reduced by 12%. And the Oxford Family Planning study of more than 17,000 women showed a similar mortality reduction. So these are safe interventions and they offer many protective benefits for women as they go through their 40s. Thank you very much.